Autism and Complex Care Needs, 5th of October 2020. My name is Mary Leroy. I'm a nursing officer for the Mental Welfare Commission in Scotland. This presentation will also be presented with my colleague Yvonne Bennett, who is a social worker for the Mental Welfare Commission in Scotland. With the use of language, within the autism community, some people reject the concept of autistic spectrum disorder. Some people prefer phrases such as autistic adults, and others prefer on the autism spectrum. To reflect a range of perspectives, terms we will use in this presentation will be interchangeable, but we will generally use the term autistic people. This is the first time that the Commission has visited, and on a themed visit looking at the support of autistic people with complex care needs. Our visit, as I said, focused on individuals with complex care needs. Autistic people with complex care will often be treated and supported in hospitals or care services which are primarily designed for people with learning disability or mental illness. We had wanted to see if the particular needs relevant to autism were being adequately met in these settings, and also to look at some services which specialised in the support for this group of adults. We were also concerned about people spending long periods of time in hospital and about whether services were responding to the challenging behaviours that some individuals may present, and that at all times their human rights were being respected. The definition of complex needs can incorporate a learning disability, physical disability, mental illness, acquired brain injury, or dementia. They can often be combined with physical health needs that might include epilepsy or sensory issues. The term may also reflect behaviour that is perceived as challenging. Our visit focused on people who primarily had a diagnosis of autism. They would have significant and complex care needs. The age range was between 18 and 65. We visited people in NHS adult acute services, in IPCUs, learning disability inpatient wards and units. People were subject to formal civil orders under either the Mental Health Care and Treatment Scotland Act 2003 or Adults with Incapacity Scotland Act 2000. And we also visited some specialist services, autism services. We visited the Mitford Unit Assessment and Treatment Service in Northumberland, also a specialist assessment services in both Dundee and Alloa, and a community team in East Renfrewshire who were supporting staff who were also supporting individuals who had an autistic diagnosis. Further details regarding some areas of good practice can be found in our fuller report. We saw 54 individuals, 28 of them were in hospital and 26 in a range of community services. They were either subject to at least one legal measure, 28 were subject to the Mental Health Act, and 46 were subject to welfare guardianships under the Adults with Incapacity Act. 20 were subject to both guardianship and an order under the Mental Health Act. The policy background that we reflected and referred to when we were undertaking this themed visit, as we all are aware, in the last decade, autism has increasingly been seen as a policy priority. I'm sure you're all familiar with the legislation, the background legislation, and I'll just leave that a minute for you to have a look at. Following consultation with stakeholders across Scotland, they identified for us 4 themes that they felt were really important in relation to the care and treatment of individuals with complex care needs. They had asked that we focus on assessment and diagnosis, on treatment, support and staying well, and on crisis. When we set about doing any of our themed visit, we always look for the gold standard of what we would expect to find. For us, we were looking for anyone thought to have ASD should receive a full diagnostic assessment together with a profile of the individual's strengths and needs. This is to be carried out by a multidisciplinary team which has the skills and the experience to undertake the assessments. There should be post-diagnostic support and a thorough assessment of the need for services. What we actually found: everyone we visited had an assessment. But we did find a variation in the process of assessment, and particularly in the provision of the post-diagnostic support. We heard that in some areas, another diagnosis, such as having a learning disability, may mean that a possible diagnosis of autism may not be pursued, while in other areas, a referral for ASD may be rejected unless the person has another disability. We were also concerned about the loss of specialist expertise because of changes in organisation of services. There are particular problems carrying out specialised assessments in more rural and remote areas in Scotland. Where there are specialised services in place, they can have significant pressures, and some respondents said that there were lengthy waiting times for both assessment and diagnosis. Although in other areas, the multidisciplinary teams, the waiting times were low. People described a wide range of experiences of assessment, where there was a sense of collaboration between the individuals, the families and the professionals. The experience of assessment was described positively. This included having the opportunity to discuss the diagnosis with the team, access to information, leaflets, websites, and many carers specifically talked about the value of peer support. All of these services being in place added to a positive influence of the experience for both the individual and families. However, many of the families we spoke to felt let down by the provision of post-diagnostic support. Some of the assessments were done several years ago, but evidence from professionals suggested that many do not provide assessment and post-diagnostic support that actually meets the expectations of the signed 145 guidelines. We were concerned about this. Our recommendations are a suite of recommendations, and as we go through this presentation, you will see how they all fit together. However, recommendation 1 and 2 are for: initially, NHS boards should ensure that they are able to provide a comprehensive assessment and diagnosis for any person who may have autism spectrum disorder and complex needs, which meets the standards set by signed guidelines 145. The second recommendation is that integration authorities should ensure that any person with a diagnosis of autism, whether or not combined with another condition such as a learning disability, is given access to an appropriate range of post-diagnostic support, and that a plan for this is agreed with the adult and, where appropriate, their family. In this slide, we look at treatment. Again, when we will lay down what we would expect to find, the gold standard, what we would like to see. We would expect that autistic people with complex needs will receive appropriate person-centred and holistic care and support with the involvement of the multidisciplinary team. They will only be treated in hospital where they have specialist health needs which cannot be safely met in the community, with arrangements in place for a timely return to a community setting. And all treatments will be properly authorised with proper safeguards. What we found, the multidisciplinary team working. Generally, we were satisfied that multidisciplinary work was in place and operating appropriately. We were pleased to see examples of a person-centred approach supporting the individual's strengths, and family and carers were also involved. Interestingly, when we looked at speech and language therapy, half of the people we had reviewed had input from speech and language therapy, but some carers were concerned and stressed that there were difficulties in accessing adequate speech and language support within a community setting. It's estimated that 60 to 70% of autistic people have a sensory modulation processing disorder. Occupational therapists have a unique role in the assessment, diagnosis, and treatment of sensory issues for autistic people. We found some example of sensory assessments. They proved extremely helpful to staff in recognising triggers for increased anxiety and being better able to avoid or respond to these. It resulted in improved communication for the individual and a reduction in the use of as required medication. Some professionals commented that this service needs greater recognition. For psychological therapies, we acknowledge that there are a variety of approaches available to support individuals. However, in this report, I think linking with the complexity of the individuals with autism that we met with, the model we saw most being evidenced in practice was a behaviour support, with positive behaviour support, That's a set of strategies used to increase the quality of life and decrease behaviours that challenge. It teaches new skills and makes changes in the person's environment. The government have committed to further investment in PBS. We found good evidence of this model being used in the hospital setting. It develops a stronger understanding of the context in which behaviour that challenges can occur, and it supports the involvement of both the family and the individual in planning their own support. However, access to the necessary support to pursue a PBS approach was less evident in some social care settings. Medication. Psychotropic medication such as antidepressants or antipsychotic medication can be routinely prescribed for autistic people. But we would like to stress that it should only be used in the treatment of individuals who may have a comorbid mental health condition. Antipsychotic medication is also used at times to manage behaviour that challenges. Guidelines support the use of antipsychotic medication in conjunction with psychosocial approaches to manage severe behaviour that challenges people with autism. But we must stress this is only where psychosocial approaches alone have failed. Medication. In general, we were satisfied that those who were given medication on an as-required basis had a clearly documented care plan relating to this, and that appropriate legal authority was in place. The individuals reviewed had complex needs and often severe difficulties associated with their ASD. I'd like to stress that we did not undertake a clinical review of individual cases and cannot therefore comment on the appropriateness of prescribing medication to any one individual. Nevertheless, we were concerned about the figures we found. In England, there is an initiative to reduce overprescribing of antipsychotic medication amongst people with learning disabilities. And previously in Scotland, there have been successful initiatives to reduce such prescribing for older people with dementia in care settings. We believe it is time for a concerted effort to do the same for autistic people in Scotland. This led us to this recommendation with regards to psychotropic medication for autistic people. The Scottish Patient Safety Programme should develop and lead an initiative to reduce the use of psychotropic medication with autistic people for the management of behaviours perceived as challenging. Thank you. I will now pass over to my colleague Yvonne Bennett, who will take you through the next 16 slides. Thank you.
Okay, thank you. Moving on, we will look now at some discharge planning. This was a big issue for us during the report. And really the background to that was that in 2016, the Mental Welfare Commission conducted a theme visit called No Through Road. And during that period, we visited 104 people across 18 hospital units for adults with learning disability. And 32% of these people were experiencing long waits for discharge from hospital. And at that time, 2016, there was a number of causes identified for that: a lack of funding, a lack of suitable accommodation, or a lack of suitable providers to provide care packages. But more often than not, it was a combination of all three. That was in 2016, and that prompted a further report which was commissioned by the Scottish Government, the Coming Home report, which Mary referred to earlier, which looked at out-of-area placements and delayed discharges for adults with learning disability and complex needs. Of this group, there was 705 people who were placed out of area, and of that, there was 109 were classed as priorities to return to their own area. And of this priority group, 50% of this group had a diagnosis of autism. So it was disappointing that during this visit we found really that little had changed. Our theme visit highlighted that still there were large numbers of people with learning disabilities, including people with autism spectrum disorder, who were continuing to experience lengthy delays in being discharged from hospital. Of the 28 people we visited in hospital during this visit, 13 were classified as delayed discharges. And disappointingly, the causes for delay continued to remain the same: financial constraints, lack of suitable accommodation, and difficulties commissioning suitable provider. Next slide, please. So we saw that the issue of significant delays in discharging someone from hospital is long-standing and pervasive, but we found that it wasn't insurmountable. We found that the promise of more joined up, seamless delivery of service that integration had promised has sadly still to be realised for the adults we visited. And people continued to spend long periods in hospital due to ongoing complexities associated with funding or differing approaches by health and social care services. One example we saw was where health and the preferred provider used different models of physical restraint, which was a necessary component of the adult's care plan. This in turn made joint working and planning for discharge even more difficult than it needed to be, and further prolonged the young man's hospital stay. It would be unfair, however, not to note that we did see some positive examples where comprehensive planning, joint working, and creative commissioning had resulted in discharge from hospital to a community setting for adults with really complex needs. And we were heartened by the positive outcomes this achieved for them and for adults who'd spent otherwise long periods in hospital. We looked at commissioning bespoke services for adults and ensuring robust training and plans are in place to support adults in the community with complex needs. As a result of these findings, the following recommendations were made. We recommended that NHS boards and integration authorities should ensure that they have arrangements in place to secure community provision for any autistic person with complex needs in hospital within 6 months of their being assessed as able to be supported in the community. This should include discharge planning coordination from the point of admission. So the earlier the process starts, the better. We realised that this recommendation was aspirational, but we were keen that some concentration on progressing hospital discharges is forthcoming. Recommendation 5, we asked the Scottish Government should monitor delivery by the NHS boards and integration authorities of this recommendation, and where there were difficulties and barriers to delivery, that the Scottish Government worked with the NHS boards and integration to remove the barriers and to facilitate earlier discharge to suitable community placements. The next area that we looked at as a result of stakeholders identifying as a priority is this about support and staying well. And our view was, what we expected to find was that people wherever they lived should have a range of meaningful and enjoyable activities tailored to their needs, and that these should support a well-being agenda in its widest sense rather than a purely health promotion objective. They should be able to access their community and maintain family links and friendships which are important to the individual. And to do this, care plans require to be outcome focused, tailored to the individual, and work with the person to develop their skills and maximise their independence. To do this, accessible transport would be available, as this was a vital component of being able to do this, particularly in rural communities. We also expected to find that physical health care would be met to the same standard as any other citizen would expect. And the importance of the person being at the heart of any decisions about themselves can't be underestimated, and we expected to see easy access to independent advocacy to support this where required. What we found was we heard actually many positive stories demonstrating how people with complex needs could be supported to participate fully in the community and to take part in volunteering, sports and creative activities. But we were disappointed to find that 1/3 of those we interviewed did not have structured, personalised activities. Hospital timetables were limited and unimaginative, or relied on family members taking the adult out. And in the community, one professional commented that the lack of structured, meaningful activities available in the community means that boredom can be a factor which negatively influences a person's presentation. Funding cuts to community support services, leisure activities and college courses is having a huge impact and increasing referrals to health teams. And we also found a very variable access to advocacy services across the country. Our view very strongly was that these services should not be seen as optional extras. Under the Mental Health Act, local authorities have legal duties to secure a range of services for people covered by the Act, including people with autism. These services include care and support to give the people the opportunity to lead lives which are as normal as possible, access to social, cultural and recreational activities, transport and advocacy. Many autistic people have other physical health conditions, including epilepsy, gastrointestinal problems or infections. And where people have communication difficulties, the diagnosis of these can be complex and difficult. And it's important that anyone in a care setting has their health care needs monitored. We saw that where a person has complex health needs, a range of treatments and supports were evident, but what was lacking was the more routine health checks. For example, dental health care, which can have a significant impact on a person's well-being. And we saw less evidence of these lower level routine health checks. We were disappointed to find that only half of the people we reviewed had an easily identifiable record of an annual health check. And those services should be seen alongside the range of other treatments and supports which a person with complex needs will require. And the carers we spoke to stressed the need for better, more personalised coordination of all aspects of care, particularly for people with complex healthcare needs. Often we heard that there was a range of health services involved, but carers often reported that this became confusing and difficult to coordinate. On the basis of that, we made a recommendation that integrated authorities should ensure that autistic people with complex needs in community settings have a dedicated coordinator to oversee the full range of provision to meet their needs. And these should include access to speech and language, occupational therapy, and psychosocial interventions which meet the standards set by Sign 145, which Mary alluded to earlier. It should include the promotion of good health, including access to basic health screening and an oversight and coordination of complex health needs. It should include a tailored activity plan which addresses the need for a meaningful role and routine, including self-care, education, employment where appropriate, and leisure activities. And finally, it should include support for family carers, including ensuring that a carer's assessment is offered where appropriate. The final area we were asked to consider as part of the theme visit was how services respond to crisis. We were very clear that what constitutes a crisis for an individual is varied and is very person-specific, and so too is how best to respond and support them at these difficult times. In some clear plans developed with the family and the adult, where possible, setting out how to reduce the risk of a crisis occurring and what to do in response to this crisis. And we felt that where people may require to be restrained, that this should be done safely, and lessons learned for future management of crisis situations. What we found was that the majority of people we spoke to did have a crisis care plan in place, and that individuals, families and staff found them helpful, and that they had contributed to the formulation of these crisis care plans. We found really good examples of the crisis care plans in both hospitals and community settings. We heard from families and from services that at these points of crisis, that rapid access to multidisciplinary team was seen as important. And sometimes for those in the community, that access to hospital was important at these times as well. Restraint featured in 16 of the 28 hospital patients we visited, and 4 people in the community. And where welfare guardianship was in place, the use of restraint had been specifically considered and authorised in most cases. And on the back of that, we made the following recommendations. We thought that the work of the Scottish Patient Safety Programme to reduce the use of restraint in mental illness settings should be extended to NHS and community services supporting autistic people with complex needs. And we also thought that the NHS and community services should ensure that they have policies concerning restraint and seclusion affecting autistic people with complex needs, which included consistent recording, feedback, staff training, and improvement plans to reduce their use of restraint over time. We focused this recommendation towards the Scottish Patient Safety Programme due to the work that they've done in mental health settings, which has been really successful in reducing the use of restraint without compromising safety. And we thought that we could learn a lot from this approach. Another topic that we wanted to explore and we felt was important to consider was the impact of the environmental issues on autistic people. We saw one example of how a very minor change to an environment resulted in a more positive outcome for the patient, and this was where staff on the ward silenced the bleep made by their fobs as they came in and out of the ward, and how such a small change in what was happening within the ward reduced the patient's anxiety levels significantly. We would expect to see safe, welcoming and comfortable environments which are particularly important for autistic people who are often highly sensitive to sensory stimuli, including noise, light and smells. We would expect hospitals and homes to be bright, clean and welcoming and free from excessive noise. And we would also hope to see that effort had been made to make the areas autism friendly, and that quiet areas with low stimulation and some simple decor personalised to the individual where appropriate are in place. So what we found during the visit was that community services generally had more scope to adapt the environment to suit. Overall, hospitals and care settings had thought about how to meet the needs of patients, but this had been done on an ad hoc basis rather than as a standard part of their care. And where we saw the involvement of occupational therapists in assessing sensory needs, outcomes for autistic people were greatly improved. So on the basis of this, recommendation 9 was that NHS boards should ensure that there is an individualised environmental and sensory assessment whenever a person with autism is admitted to a mental health or learning disability ward, using an appropriate assessment tool which is reviewed with the person regularly during their stay as an inpatient. We looked at what training staff had to meet the needs of adults with autism, and what we expected to find was that all staff working with people with autism should have received autism-specific training appropriate to their needs. And we used as a benchmark for this that in 2014, NHS Education for Scotland published the Autism Training Framework, Optimising Outcomes. And this framework details the knowledge and skills required at different levels within the health and social care workforce to achieve key outcomes for people with an autistic spectrum disorder, their families and their carers. However, what we found was that staff were aware of the training framework but hadn't routinely used it to ensure that they were trained appropriately for their role. Within the third sector and private agencies, often autistic people are fitted into existing services either for mental health or learning disability due to autism-specific services operating to full capacity. We understood the need for that, however we felt that this could be ameliorated by ensuring adequate targeted training is available, and that once the training has been delivered, that there's competency framework monitored to ensure compliance and that the standard of service that people are receiving is of an appropriate and adequate level. So on the basis of that, the recommendation 10 was that NHS boards, local authorities and integration authorities commissioning services should ensure that anyone who's providing services to a person with autism and complex needs is trained to the appropriate level of the NES training framework and, where appropriate, receives ongoing and clinical supervision. We wanted to hear about the needs and views of carers for adults who have a diagnosis of autism. And all of the families we spoke to described significant distressing and often ongoing negative effects that the diagnosis and subsequent care has had on their families. We heard that it could be difficult to maintain a family unit or to have any life as a family to ensure the care of siblings. Most of the carers we spoke to hadn't been directed to any support for themselves, and only 2 had had assessment of needs in their own rights as carers. Sadly, we saw no evidence that the new rights for carers introduced in the Carers Scotland Act 2016 had made any positive difference for this group of families. We asked if there was one thing carers could identify that would make a positive difference. And we heard that the ultimate aim of most carers was to have the individual in a well-supported community placement, managing to live life to the full with as much independence as possible and a better range of activities for them to become involved in. We heard that coordination amongst services and streamlined care, with the suggestion of a care manager type role to facilitate this, would support and assist carers in their role. And finally, carers were keen that their opinion and unique knowledge of the individual was acknowledged and respected. We often find that carers who have provided this level of care have detailed information about nuances of a person's presentation, what works for them, what doesn't work for them, and carers were keen that this was incorporated into any care plan that was formulated for the care of their adult family member. So, in conclusion, the people that we had met had a range of complex and individual needs, and there was a wide variation in the extent to which the services were currently able to meet their needs well. We absolutely acknowledge that getting it right takes time and expertise, and we know that it can be expensive. But it was also clear that getting it wrong and failing to design services around the individual can be even more expensive, both in terms of human and financial costs, and in coping with problems which might otherwise be avoided. Equally important, it fails the individual and leaves professionals and care staff unable to give the high quality care and support that we know that they want to give. The increased recognition of the needs of autistic people in recent years has been welcomed. We now know a lot about what a good service should look like. The challenge now is to deliver that everywhere, allowing autistic people to live fulfilled lives and their families to be assured that they have the stability and personalised care that they deserve. So what do we do now? What has happened following the publication of the report was that we've also circulated that around Scottish Government, health boards and integrated authorities. And we now ask for agencies to evaluate their practice in light of this and produce an action plan for areas that they have identified as not quite yet meeting these requirements. We will collate these and report on this in due course. We also want to begin to see recognition and action from these findings within local autism strategies and action plans, and we will follow this up in the course of our duties within the Commission. We'll monitor improvements as part of our local visit programme and as part of our guardianship visits, and we will measure services that we are visiting against the recommendations that we have made in this theme visit. And finally, we are meeting with Health Improvement Scotland to discuss the implementation of recommendations 3 and 7, which deals with the medication and restraint, and we will look to monitor this on an ongoing basis as well. I hope this has been an interesting feedback from our report, and I think that it will be the first of a number of theme visits into autism services, and we look forward to your feedback on this. Thank you for listening.